Good afternoon, and thank you for joining us for today's webinar, Suicide Prevention, a National Lifeline for States. My name is Charlie Severance. I'm a policy specialist here at NCSL, where I cover suicide prevention and other behavioral health topics, and I will be your moderator this afternoon. On today's webinar, after brief introductions, we'll get to hear from several expert speakers. First, we will get to hear from Senator Daniel Thatcher and Representative Steve Elison from Utah, who will share information regarding the National 988 Lifeline and provide policy examples showing how states can support the implementation of this national number, as well as their local call centers. We will also hear from Cam Madsen, who is from Congressman Chris Stewart's office. He is his chief of staff and has worked extensively on this federal legislation. We also have Julie Eben from the Suicide Prevention Resource Center, who will share options for states to improve their suicide prevention infrastructure more broadly. After each presentation and at the end of the webinar, we will have time for questions, which brings me to a few housekeeping items. You can ask a question at any time, either for help or to pose to a speaker by typing into the chat box at the bottom of your screen. To begin building some comfortability with that function, and also to learn who's on the line today, I invite you to type the state which you are calling from now. And again, we will hold a formal Q&A after our presenters are finished presenting. I also want to briefly mention the resources. Above the presentation, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoint, as well as some other handouts. Another tab is labeled as Speaker, where you can read the bios of today's speakers. You can access these tabs at any time during the presentation. The webinar platform we are using is optimized for use in Google Chrome. While other web browsers such as Firefox may work, we recommend anyone experiencing technical difficulties try signing in through Chrome instead. If you continue to experience technical issues, please email registration@ncsl.org, where our team is ready to assist you. Today's webinar is being recorded and will be available on NCSL's website within the week. I would also like to thank our partners at the Centers for Disease Control and Prevention, National Center for Injury Prevention and Control, for supporting today's webinar and making this webinar series possible. This is the fourth webinar in a series of 9 webinars dedicated to pressing public health concerns. The next webinar in the series will focus on state strategies to address adverse childhood experiences and will take place at the same time, 2 p.m. Eastern and 11 a.m. Pacific, this Thursday, December 17th. You can access that webinar and all of the remaining public health webinars through the links in this slide. I also want to highlight NCSL's recent report on suicide prevention. While this webinar will focus on the National Suicide Prevention Hotline, our 2020 report provides much more background information on suicide in the United States, the strategies that can be used to prevent suicide, and examples of legislation to address suicide from across the United States. And now, before I turn the webinar over to our first speakers, I'd like to provide a brief overview of the federal legislation enabling the National 3-Digit Lifeline. This legislation passed both houses of Congress in the fall of 2020 and was signed by President Trump shortly after. The legislation allows for a 2-year transition period to allow for network changes and to prepare for an expected increase in call volume before all calls to the existing 1-800-273-TALK Lifeline will be rerouted to the new 988 number. While the original number will remain live and available, the hope behind this legislation is that a shorter number will be easier to remember. The legislation also provides states with the ability to collect an optional surcharge to support local call centers. This is similar to the funding model in place for 911 calls. The 988 number will not initially include the ability to text for assistance. However, it will include the National Veterans Crisis Line and provide access to specially trained responders to handle these calls. And with that, I'm going to go ahead and turn it over to our first presenter, Senator Daniel Thatcher from Utah.
Thank you very much. There is so much more than we could ever possibly cover in a single afternoon, but we're going to cover as much as we can, as quickly as we can. So let's start with this. There is a wide disparity between the ability to get crisis intervention for physical crisis and the ability to intervene for mental and behavioral. To highlight that, let me ask you this. The smallest child, if they know what a phone is, they already know how to get police, fire, and ambulance. 911 is the first phone call that most people learn. Anyone everywhere knows how to access those services. But when it comes to mental and behavioral health, when it comes to suicide crisis, how many of you on the line right now know the number? It's 10 digits. It's 1-800 something, something, something talk. That's unacceptable, and we end up losing a lot of people. In the state of Utah, the leading cause of death for Utahns, 10 to 24, is suicide. And that is sadly not unique. So to address this, we recognized initially that we need a 3-digit number. We need a simple way for people to reach out and connect to services in crisis. Our first attempt was in the 2014 legislative session, where we ran a bill that would have designated 311 as the only 3-digit number not in statewide use in Utah for a suicide hotline number. We were not successful in that effort. So instead, we created a commission. Now, if you do not have one in your state, that is the easiest and most inexpensive first step. Bringing together experts from education, from mental health, from the universities, bringing the experts together to talk about how do we better make services available has been tremendously beneficial. So through that group, we in Utah determined that if we couldn't get a 3-digit number, the next logical step was an app. So we created an app in the state of Utah. It's called Safe UT. It rolled out in January of 2016. And with this app on your phone, you can push a button and you don't have to know what the phone number is. You push a button and you're connected 24 hours a day, 7 days a week. The other benefit to using this app is that you can text. I don't know how many of you have met kids these days, but they will text people that they are sitting on a couch with. I'm sure you'll be shocked to hear this, found that 20 to 1 kids were using the texting features more than they were using the calls. We saw tremendous success with the Safe UT app, leading to 1 month where we had over 2,701 unique connections from unique phone numbers, resulting in 67,531 individual messages texting in asking for help and asking for support. To put that in context, most of these are coming from 7th through 12th graders, and for the entire state of Utah, we have 289,000 7th through 12th graders. So this app has been tremendously successful. Not only does it provide crisis communication, but it's also allowed us to receive tips. In 1 month, this is 1 month, not 1 year. In 1 month, we received over 37 unique and verified reports of weapons, explosives, or planned school attacks where we were able to intervene and get a kid into therapy instead of shot or in jail. This app is phenomenal. However, it only works because of the back-end support system. We've tried to share this with other states, and the biggest challenge that we've run into as we've tried to share this with other states is you have to have a call center and you have to answer the phone. When people call to get support, someone has to pick up that phone. In Utah, we found that we had 23 different official state-sanctioned suicide hotline numbers. 23. 11 of them went to police dispatch. Now, I don't know if you have really taken the time to think this through, but police dispatch is a terrible place to send a suicidal caller. Their job is to determine if you need police, fire, and ambulance, and to get someone rolling out to you as soon as possible, not to take what is on average a 43-minute suicide hotline call. However, that's still a better option than 11 of the other numbers, which usually went to a voicemail. Only one of our call centers in the state of Utah was staffed 24 hours a day, 7 days a week by licensed clinical social workers. So we have model legislation that you can adopt that Representative Elison and I passed, and he'll show you that slide later, that directed that for the state, the only acceptable suicide hotline number must be answered 24 hours a day, 7 days a week by qualified counselors. So there are a lot of things that we need for behavioral and mental health crisis response to get onto parity with what we have for physical health. You need a call center. Folks have to pick up the phone. You need qualified suicide hotline counselors that can talk someone off the ledge, in some cases, literally. You need a warm line service coordinators. That is, once someone is stable, they can be passed down from the more qualified therapists down to the warm line. The warm line is someone that can help find your insurance. If you're not on insurance, they can help find out if you're qualified for Medicaid and get you signed up. They can help connect you with someone that can see you on a regular basis. They can help you connect to services. You need to have someone to respond to those calls. Now, in most states, in most cases, calls that go to crisis end up getting served by either police, which we've seen does not always have the best ending, or in other cases, we send EMTs. The challenge with an EMT or a paramedic is that while they may receive some weekend training, very rarely are they really expert in mental or behavioral health calls. I have some model legislation that will be shared in the follow-up email from this that I'm running this year that directs our Department of Emergency Medical Services to add, so in addition to EMTs, advanced EMTs, and paramedics, we will be in the state of Utah adding a certification for a behavioral emergency medical services unit. I'm very excited. It's going to be a real game changer. Now, some states, including Utah, use what's called mobile crisis outreach teams. The MCOTs, as we call them, have many names. The one you probably have heard the most about is Cahoots. There are lots of different mobile crisis outreach team models, but they typically center around sending a behavioral, usually a social worker, to the scene of a call. We found those to be very helpful, very beneficial. The challenge with them is we don't, in the state of Utah, have enough qualified social workers to even see patients on a regular basis, let alone putting them in little mental health ambulances and sending them to locations, which is why having these behavioral EMS units will be a huge game changer. However, there are times when those EMS units will need a stronger response than what they can provide. So having a tiered response is part of the key. So EMS units, MCOT units, teletherapy is absolutely 100% going to be part of the solution moving forward. Having these EMS units, if there's something above their expertise, having them able to hand someone a tablet and teleconference with a therapist who is safely in his office is going to be key. You've got to then have transport. In addition, right now, most of these calls, your options are either send them home and hope they don't hurt themselves, take them to jail, which in most states, the criminal justice system is the largest provider of mental and behavioral health services, and that is something we're working very hard to change in Utah, or sending them to emergency departments where those EDs tend to be overwhelmed and tend to maybe not have the best outcomes for behavioral health patients. So the state of Utah, as many other states are doing, as Arizona is doing expertly, we have started creating receiving centers as a place to take someone in a mental health crisis so that they can be taken care of. So why don't we have these things? Well, there's two reasons. One is because it's awkward. It's hard to talk about, and because there's no one that is going to go and bang down your door and demand that you start caring about this. There are no behavioral health unions that demand support and funding the way that we see for police and firefighters and EMS. Secondly, it's expensive. It will cost a lot of money. So I am immensely grateful to both my former Senator Orrin Hatch and my current Congressman Chris Stewart that when we went to them and said, hey, we need help, they were able to take this to the United States Congress. They were able to get 988 designated nationwide as a 3-digit mental health crisis number. So having that will solve the problem of connecting people in crisis to mental health services. We have now a 911 equivalent. But here's the other issue. There's now a funding mechanism. Part of this federal legislation authorizes the collection of a 988 fee on all phone lines that is equal and equivalent to what is collected for 911. For the state of Utah, that is not an insignificant number, and it is enough that we will be able to beef up our call centers. We will be able to hire additional hotline counselors. We'll be able to hire additional service, warm line service connectors. We'll be able to hire EMS units. We'll be able to expand the use of MCOTs, telemedicine, and receiving centers. And that is now something that you can do as well. So if you are able to add the 988 service fee in your state, you will now have a dedicated resource that will help you be able to do these things. And frankly, we'd love to see the Safe UT app adopted in every state. We'd love to see all of these things. So I know that there's a lot that we have to cover. And I know that Representative Elison has some slides, and Mr. Madsen from Congressman Stewart's office can also discuss what's happening. So thank you for your time and kind attention. And I'm going to turn the time over to Representative Elison.
Thank you, Senator Thatcher. And thank you, Charlie. I'd like to tie together the recent passage of the 988 legislation with how to access, having that be the door to access crisis services in our state and potentially every state. There's a really short video that we'll queue up right now that I hope will help you understand how this all ties together.
Imagine for a moment that a fire breaks out in your home, and in this reality, 911 doesn't exist. You might call the fire department directly, but they're not equipped to come to your location and only put out fires at the fire station. And the only people that will come to you in the community are the police, who, though well-intentioned, are meant to provide a very different type of public service. This lack of a fire-specific response seems ridiculous, right? Of course we should have targeted services to respond to life-threatening emergencies, whether that's fire, law enforcement, or physical health. However, in many communities across America, life-threatening mental health and substance use crises are treated as an afterthought, receiving a response that's not specific to their unique needs. A 911 call dispatches the police, who most often bring the patient to a medical emergency room or jail, or allow them to remain in the community but without assessment, treatment, or support. We have a patchwork system, made up of elements designed for other purposes, that doesn't have the capacity to treat the most vulnerable in our communities, even though an estimated 20 to 25,000 individuals in crisis go to emergency departments every day in the U.S. So how can we improve? The only solution to delivering crisis care worthy of our communities is to build a structure specifically for mental health, substance use, and suicidal crisis that is on par with other emergency systems, like we do for medical, fire, and law enforcement. By integrating 3 core elements, we can replace the patchwork fabric of our crisis care and develop a true safety net that can serve everyone, everywhere, every time. And in the process, we can reallocate wasted financial resources to places where they can have a deep community impact. It starts with regional or statewide crisis call hubs. Call, text, and chat lines staffed by trained professionals who answer the call every time and direct people to the level of care they need. The onset of 988 is a great start. However, it will need to be supported by technology that empowers 988 to become an air traffic control for mental health and substance use crisis, enabling real-time coordination across the care spectrum. But a comprehensive crisis network cannot be built with only crisis call hubs. Additional services are necessary to ensure that a unified system of care is available when and how people need it. Services like mobile crisis outreach teams, 24/7 non-law enforcement mobile teams that go out in the community and deliver care to people wherever they are. This lessens the burden on law enforcement during situations where they're not needed and eliminates the anxiety people feel when a uniformed officer knocks on their door. and facility-based crisis receiving and short-term stabilization, facilities that say yes to every person that walks through the door, regardless of their level of need, allowing them to bypass the medical emergency departments. This not only provides specialized care to these individuals with less waiting, it also enables medical emergency departments to focus on the patients they're trained to serve, while drastically reducing wall time for police when transportation by police is warranted. With these core elements in place, mental and substance use healthcare can move out of the shadows and into the mainstream. Together, we can build an unbroken system of care that connects patients from the point of crisis to the level of care that's right for them. To learn more, visit crisisnow.com.
All right, thank you. Hopefully that video was a good overview of how 988 can be the entry door into a system of crisis care that's really the model for the nation. The current National Suicide Prevention Lifeline number is 1-800-273-TALK. In July of 2022, that number will change to 988. The old number will continue to work, but 988 will be the number that is promoted nationwide, and we expect utilization to go up dramatically. I'm going to briefly just go over real quickly what the National Lifeline is. It's currently available in every state and will play a critical role going forward. Per the slides, you can see that these slides will be available so you can look at them in more depth and look at how your state currently ranks. It is funded through Congress via the Substance Abuse and Mental Health Administration, SAMHSA. Vibrant Emotional Health is the entity that administers the National Lifeline and has been in place since 2005. They work with crisis call centers across the nation. There's currently 180 of these crisis call centers in all 50 states. When you call, you're given the option one. If you hit one, you're connected to the Veterans Crisis Line, which is also funded by Congress. If you press two, it's the Lifeline Spanish language. And then if you don't press any buttons, you're just routed to the closest crisis call center nearest you based on your area code, not based on where you're at physically. That's something we're trying to change. Last year, there was 3.5 million Lifeline calls, and the respective centers fielded over 12 million crisis calls. 87% of those related to a suicidal crisis or a substance abuse issue, and the annual call volume growth last year was 14%. So very robust growth. We won't do this now, but if you go back to the presentation, you can click on this link to see a specific report for your state and how responsive your state is to the calls that come from citizens in your state. You can also see the answer rates by state here vary widely. Can you imagine if you called 911, if you had to wait for your call to be answered? That is very frustrating. And the impact of COVID, a recent article in the Lancet Medical Journal indicates that 20% of individuals that have recovered from COVID, 90 days post-recovery, are suffering from a mental illness. We don't know the impact that this will be on society, but we know it'll be extensive. A recent CDC report found that 25% of young people surveyed, 18 to 24, had seriously considered suicide in the 30 days prior to completing the survey. The history of 988, we're proud to say, began here in Utah, where we tried to get a 3-digit number, myself and Senator Thatcher. We realized that both due to technical difficulties and due to the benefit it could have for the rest of the nation, that we should seek this proposal for the whole country, which is where Congressman Chris Stewart and Senator Orrin Hatch came in. The FCC released a study in August of 2019 recommending 988. Then the FCC finalized that rule in July of 2020, formalizing the numbers 988. And then in October, just this past October 17th of 2020, the National Suicide Hotline Designation Act passed, and that also gives it the congressional seal of approval, and also charges the FCC with looking at the feasibility of geolocating and also what the cost of ultimately rolling this out will be. And again, this bill allows for states to designate a fee for accessing or putting a fee on phone bills to pay for the cost of the crisis services on the back end. It helps to know a little bit what the current landscape is with 911 and the fee implementation by state. It's very analogous to fees for 988. It won't go through these into too much depth, but there are some definite guidelines states need to follow if they're going to enact 988. But if a state is struggling financially, which many states are, looking at this new funding mechanism will be an important option to find funding where other sources that have traditionally been available may not be an option with some of the COVID-related issues. This is a very important slide here. Vibrant Emotional Health, that is the contractor with SAMHSA to run the Lifeline, is offering grants available, open to all 50 states, to help develop a clear roadmap of how they'll address the key coordination, capacity funding, and communication strategies that are foundational to the launching of 988 in July of 2022. Plan for the long-term improvement of in-state answer rates for 988. The deadline for this is coming up. They just announced it last week. The applications are due January 8th. So if you are a legislator that's just hearing this, I would strongly encourage you, if this was of interest, to contact the individuals in your state government that oversee mental health and see if they're aware of this. There's a link in this slide regarding those planning grants, which are now open to apply for. With that, I will turn the time back to Senator Thatcher to briefly run through some of the legislation that we have passed here in Utah that helped pave the way to improve crisis services.
Thank you. Let's see, is that set up under slides there, Steve?
Yes, and I can run through them if you'd like.
Yeah, if you'll pull them up, I'm happy to discuss them. Or it's probably easier at this point. I'm hoping to give Cam an opportunity to talk. One of the questions that's popped up here is, can this be used for public education? And the answer is, it depends. It can be used for things that are directly related to 988, those who are using 988 to get services. And so with 988 being a contact that school students will be using, then yes, under those circumstances, it can be used. But the funds are for 988 and for the treatment of those who call and use 988. So my first thought was, if you wanted to find a way to use this for education, something like the Safe UT app for your state would be covered, because you're now using the 988 system, you're using the call center, you're using the dispatch teams, and you're using the follow-up care. Steve, if you'll pull up those slides, I'll be happy to go through the bills. Otherwise, go ahead and pull them up, and you can.
Senator Thatcher, you should be able to see them if you click on the slides tab right next to Video Bridge.
Okay, so I just go, all right, where is the first? Let's see. If you could pull them up, I'm not seeing them immediately, and I don't want to make people wait while I try and find them.
Okay. All right. I've got them pulled up here. Just real quickly, the first slide here shows the suicide mortality rates by state. As you can see, some states have a larger challenge with suicide than others. But suffice it to say, nationwide, since the turn of the century, rates have been increasing dramatically across the nation. The Rocky Mountains have a particularly acute problem. Sometimes that's called the suicide bill. Don't have time to go into the reasons why, but suffice it to say, it's a serious issue for every state. One of the bills that myself and Senator Thatcher first passed in Utah was the School Safety and Crisis Line that created a commission to look at options for students to anonymously report school safety tips, as well as to seek crisis intervention. That brought the stakeholders together. In 2017, we also created a crisis line commission to look at how we can integrate the various 20 crisis lines that we found that we had across the state to make sure that no call for help went unanswered. That led to the passage of HB 41, Mental Health Crisis Line Amendments, otherwise known as Hannah's Bill. The young woman pictured in this slide took her life after a call for help tragically went unanswered. Her mother, also pictured there, Laura Warburton, was a champion for this bill. This bill put funding towards improving our crisis line services in the state and making sure that no call for help would go unanswered.
You'll also notice as he pulls these up, the status on each one of these bills is almost exclusively, they're almost always unanimous. The last number there is number absent. So you'll see that most of these bills in the state of Utah passed with bipartisan support unanimously and bicamerally.
Thank you, Senator Thatcher. I like to say not only is this, it's bipartisan for sure, it's really nonpartisan. These issues are so fundamental to everybody. Then we also passed SB 31, Utah Mobile Crisis Outreach Team Act, that formalized the kind of supervision and process by which these mobile teams can go out and help people in their moment of crisis. Again, very strong support for the passage of that bill. This chart right here, we could spend a lot of time on, but it's basically shows that if you have 100,000 people that call the crisis line, they can stabilize about 90% of the people by just calling the number. And on average, it's about $40 a call when you take the total cost divided by the number of calls. If you have to dispatch a mobile team for about the 10% that can't be stabilized at their home or wherever they're calling from, the mobile team visits about under $400 typically. It's, again, like a mental health ambulance. You can typically bill Medicaid for that if your state plan allows for that. Again, this is keeping people out of the emergency room. The mobile team, if they can't stabilize them, can transport them to a receiving center, a 23-hour crisis center that a number of states are now investing in, far better than taking them to jail, far cheaper and more therapeutic typically than taking them to an emergency room. And then if they can't be stabilized there, which again, we're narrowing down the number of people that can't be stabilized through these services, they can move to subacute hospitalization and then to full inpatient. But out of 100,000 people, only about 50 people would end up in a full inpatient hospital setting. Now, many states don't have these middle options in terms of mobile crisis outreach or short-term observation. And so they just bypass those and go right to the emergency room, which is very costly for Medicaid systems. The last slide was a bill that myself and Senator Thatcher passed last session that kind of pulled all those elements together with funding for receiving centers, funding for MCOT teams throughout the state, and we even expanded the Safe UT for adults, for healthcare workers, for law enforcement, firefighters, and first responders. So for sake of time, these slides will be available. They're all hot linked when you launch the presentation to the Utah Legislature's website, so you can look for additional details. Thank you.
And I'd like to invite Mr. Cam Madsen, if you'd like to just say a few words about the bill and highlight what's really important for state lawmakers to know about this federal legislation.
All right, yeah, really quickly, Senator Thatcher and Representative Eagleson kind of ran through most of the highlights as far as putting this bill together. One thing that I did want to give for all of you folks on the line is answering a little bit of the questions that I've seen so far in the chat. So Senator Thatcher hit on this where the funds that you can use that would be collected through this service can only be used for that is in support of 988 services and enhancements of those services. So they can be used for public education. If you write into, and it is all going to depend really on the laws that each state would adopt that would collect these fees as they come up. Another thing that I wanted to hit on was, let's see here, it was this question. If we had any opposition putting the fee language in the bill, this is part of how this all came together. The FCC actually acted on their own in, I think it was July of this year, it may have been June, to go ahead with the rulemaking, which would set aside 988 as the National Suicide Hotline. What they were not able to do was also authorize states to impose a fee on 988 services. As all of you know, all government functions and services cost money. That's just kind of what it is. And a lot of states have had challenges as they have tried to fund their own suicide hotlines. And what we wanted to do with this legislation was give states an opportunity to treat 988 much the same as we treat 911 right now, where states are authorized to collect a fee on every single telephone line that funds the 911 service, and this would allow them to fund the suicide hotline 988. The opposition to this was not really, it wasn't a really hard push on this. And I think that's because most of the people involved in this, whether they were telecommunications providers or like my boss, who's a fairly conservative, well, very conservative member of Congress, and has told, I told the story many times. I didn't go to DC to raise taxes. His argument here, and this is something that Senator Thatcher would say, that this is a user fee, and what this does is it funds the 988 service with those that actually use the telephone. So if you use the telephone, you're also paying in kind to this. The pushback was not hard enough that we had to change any of the language. And if you look at our legislation, we have members of Congress who co-sponsored it, who run from the very far right side of the spectrum to the very far left side of the spectrum.
All right. Thank you so much for that, Mr. Madsen. And we will go ahead and now begin the question and answer section of today's presentation. And I know we've already started to address a few of these. So if you have questions, please feel free to put those into the audience chat.
Charlie, if it's all right, I'd like to start with a conversation about the pushback on the taxation. Just because I think that's something that's been asked in the audience chat that I think is really important to address. So to be clear, this is legislation that we are presenting. It has not yet come up for a vote. I'm finding very, very strong support in the Senate because our Senate president is someone who really understands the ravages and the damage being caused by our habitual failure to address behavioral health. Again, where it's the leading cause of death for Utahns 10 to 24, there's no one in the state of Utah that has not been affected in some way by suicide. And so, yes, there will be some pushback from people arguing that it is a tax, which is why I think that the approach that Congressman Stewart took to the funding mechanism is so important. The language is equal and equivalent. Equal and equivalent to what is collected for 911. And so when you are dealing with people who are pushing back, the question I start with is, well, should we fund 911? Should that be voluntary? Should we require donations? Should we fail to provide police, fire, and ambulance if if we don't have enough people voluntarily contributing to that? And I think the answer is clearly insane. No rational person would argue that we as a government, no matter how libertarian leaning you might be, I don't think you can find a rational person that would argue that the primary responsibility of the government is not to preserve the God-given rights of life and liberty and to pursue happiness and the pursuit of happiness. So to me, as a conservative Republican, it is pretty easy to defend that we have a moral obligation to provide the same level of support for mental and behavioral health that we have for physical health. Some of the questions that people have asked are things like, well, but you're not going to have the same level of usage on 988 as you get on 911. First off, we don't know that that's true, but presuming that it is true, the average suicide call to our suicide hotline, the average call is 43 minutes as compared to the average 911 call, which is much, much faster. So the level of support needed, in my opinion, equal and equivalent to 911 is the appropriate approach. Now, the best way to get past folks arguing that we shouldn't do this because it's a tax, first off, it's a user fee. It's like 911. It is a fee that you pay because you have the benefit of having a telephone line. It's like paying for a fishing license. The solution, the easiest and best solution, is to build coalitions. So going to groups like your Chamber of Commerce, especially if you know that someone that is very influential with your Chamber of Commerce has experienced a suicide loss, it is much easier to go to them and get them on board. So with my Chamber of Commerce coming out in support of this, with my PTA groups coming out in support of this, with, believe it or not, I think that I'm going to get an endorsement from our Taxpayers Association on this because their president is a man named Howard Stevenson, who understands the critical need for mental and behavioral health services. So if you get the right groups on board and coming out in support, it makes it very, very hard to oppose this.
All right. Thank you, Senator Thatcher. Please keep those questions coming. If we do not get to all of them on the live feed today, we will follow up with you afterwards. So please, as you have those questions, put them into the audience chat. And for the sake of time, I do want to move on to our second presentation, which is going to focus on suicide prevention infrastructure more broadly. And for that, I'm going to turn it over to Julie Eben from the Suicide Prevention Resource Center.
Thank you, Charlie. Sorry, I had to figure out there how to unmute myself. There are a lot of various windows going on within this platform. And thank you to my fellow speakers. That was a very informative presentation, and I'm excited to hear all of the fabulous things coming out of Utah in particular, and also about the more details on the 988 funding. So as Charlie mentioned, my name is Julie Eben, and I am Manager of Special Initiatives at Education Development Center as part of the Suicide Prevention Resource Center project. And just a quick disclaimer, we are funded by SAMHSA, Substance Abuse and Mental Health Services Administration, but these do not represent their views, nor CMHS or HHS. So the Suicide Prevention Resource Center is really your go-to resource since 2002, when we are created for various aspects of suicide prevention, programming, toolkits, best practice models, online trainings, and more. And we serve a wide variety of the spectrum of folks doing suicide prevention, from community level organizations, people who have had personal experience with suicide, to making some broad recommendations on infrastructure, which is what I'm here to discuss today. So I'm going to do a really brief background on a couple of data points, but I'm not going to spend too much time on that. I'm going to provide an overview of the Suicide Prevention Resource Center, or SPRC's, recommendations on suicide prevention infrastructure for states, and talk really about how the recommendations can help you as you do this critical life-saving work in your states. So as you saw, suicide rates have been increasing over the last decade. In many states, they have gone up over 30%, and really, since 1999, it's been quite critical in the nation. These are the latest national numbers that we have access to from 2018, and obviously this doesn't even take into account the COVID experience, but you can see that rates have continued to climb. So with the increases, as was mentioned about the Lancet article, the increases in mental health needs brought about by COVID-19, especially, we really see a real need for suicide prevention, but also a real opportunity. And this is a very real leading cause of death in your communities that you can help fix. And I think that one thing that we've experienced with COVID-19 is that it's really shining a light on the need for long-term mental health supports during this time period. So there was hold on, I think this slide may not be quite showing up properly. My apologies. Let's just see. Oh, there we go. Okay. So there was a CDC vital signs publication a few years ago that talked about some different contributing factors to suicide. So it's not just a mental health crisis. 54%, I believe, of suicide deaths did not have a known mental health diagnosis. Now, it's not to say that they didn't have an undiagnosed condition, but there are other problems that can contribute to suicide, such as relationship problems, substance misuse disorder, financial problems, physical health, criminal proceedings. And so it's really to say that it needs not only supports for crisis intervention, such as the 988 lines and some of the other amazing innovations that were discussed earlier regarding Utah that may be, definitely useful to replicate in other states as well, but also to really do some upstream intervention. So not at the point of crisis, but really preventing some of those earlier risk factors, or building up protective factors during some of the crises that are highlighted on your screen. We know what works to prevent suicide through evidence-based research, such as through the CDC technical package on suicide prevention. And in the resources tab, there are several handouts, including one that has a few different links on it. And there is a link in there to the CDC suicide prevention technical package. But just like our roads infrastructure, which can be decaying or missing in many areas of the country, our suicide prevention infrastructure has a lot of potholes, or in many cases is dirt roads. One study that looked at the impact of funding on suicide prevention showed that with funding, youth suicide decreased. This was a youth suicide prevention program. But 2 years after the funding went away, rates began to rise again. This was a national Garrett Lee Smith youth suicide prevention grant. So having stable infrastructure is more cost effective than the sort of boom bust thing that can often happen when funding is reliant on grants. So time, talent, money, momentum are built and then lost and then rebuilt. And it's really, wasteful and very inefficient. In order to get to the solution to suicide, infrastructure needs to be predictable. And the funding really needs to go along with the number of deaths and serious attempts and not be sort of really unrealistic to what's needed. So I just wanted to quickly define suicide prevention infrastructure. So what are the practical foundations or frameworks that support overall suicide prevention systems, organizations, and efforts? All right, so in 2019, Suicide Prevention Resource Center conducted research on suicide prevention infrastructure, and we had an advisory panel of over 20 state and national experts in various disciplines: suicide prevention, rural concerns, veterans, youth, public health, mental health, including people who personally had been impacted by suicide in one way or another. And we divided these recommendations into 6 essential elements. So you can kind of see this bubble chart here. And I'm going to get into a couple of specifics on those. So the first is authorize. Since suicide is both a public health issue and a mental health issue, prevention activities may fall under the responsibility of a number of different state agencies, or may be conducted by many other nonprofits. And it really needs to be clear who's leading the charge here and have that be designated, so that other people, can sort of look to them as the leader. Not to say that other folks should stop what they're doing, but it really needs to be kind of clear who's directing the traffic and who's steering the boat. Resources also need to be authorized so that lead agency and others can build the infrastructure and carry out a comprehensive plan. And it's really important to have regularly scheduled updates to the state plan, not one that is 10 years old and out of touch with today's need. Second essential element is lead. Suicide prevention efforts are more likely to succeed when they have consistent leadership. So I referenced some grant funding earlier. One state that I worked with relied on a significant federal grant for the sum of their suicide prevention activities. And they had a wonderful grant coordinator who had done amazing work in the state, who acted as their suicide prevention coordinator. Their grant came to an end. They reapplied for the next one, feeling sure that they would get it. But the way the grants were structured had changed this time around. There were fewer grants for more money and they didn't get it. So they had to lay off their suicide prevention coordinator. Some of the other recommendations in this section and other places in the list are ones that your suicide prevention leadership in your state government and your coalition can carry out, but they really need your support in order to do it. So the third essential element is partner. As described in the National Strategy for Suicide Prevention, you really need to have a public-private partnership to increase the effectiveness, reach, and impact. And this can sort of help fill in gaps and avoid duplication. Examine, which is around looking at the unique data in your state together with your suicide prevention leaders, and let that guide where to focus your efforts. If the majority of deaths are taking place in middle-aged white male veterans, and there's a very large suicide attempt rate among Native American youth in your jurisdiction, then that's really where you need to focus your efforts using evidence-based methods. And the last 2 elements are build and guide. Suicide prevention really needs a multifaceted, evidence-based approach, and local efforts need guidance to have the best impact that they can. So the SPRC website has a wealth of strategies that work. For example, Washington State has a clinician training requirement, and because clinicians really traditionally have not gotten a lot of suicide prevention education, even during their clinical training. And so SPRC has some information about what's going on in various states, as well as best practices and the evidence base. So in the handout section is a summary of the state suicide prevention recommendations. And there are a lot of recommendations there. Some are the green star level are the sort of basic recommendations, and the yellow plus signs are the sort of, if you want to go further. But there are a few that I really wanted to draw your attention to as things that you can influence. So I mentioned designating a lead agency, providing administrative support and continuity of effort, maintaining a dedicated position, not to say that that one person can do it all, because they can't, but that they need at least that, and having a statewide coalition or some other body. There are some other mid-stage recommendations that you can look through as well at your leisure. So I guess the key thing that I want you to walk away with, there are a number of tools, some of them on the handout section. But what I really want you to walk away with is, as I mentioned, the infrastructure needs to be predictable, not this sort of bust boom economy. Funding needs to be commensurate with the number of deaths and serious attempts. And there are things that you can do. You have helpers, people you can turn to in your state. In the handout, there is a link to a list of suicide prevention leaders in your state, whether they are a designated coordinator funded in that capacity or your coalition co-chair. There are other key folks that you can turn to, local advocacy organizations like a local chapter of the American Foundation for Suicide or NAMI. If you have a tribal liaison in your government, and every state also has a suicide prevention coordinator at their VA. So I really encourage you to get in touch with those folks to be able to find out what is needed in your state and who can advise you on this. Thank you.
Great. Thank you so much, Julie. We are right at time. So I did just want to quickly remind everyone about our upcoming webinars in the NCSL Public Health Webinar Series. And for those of you who need to log off, I will also remind you that we are going to follow up with you over email if we did not address your question here in the live feed, but also follow up with all of the additional resources that will be mentioned if you have to log off right now. I did just want to take at least one more quick question right now because we got a pair of them that were fairly similar. Are the 23-hour crisis receiving centers for just mental health, or do they also treat individuals with substance use issues? And then a similar question, can the funds also be used for substance use disorder crises? Will the 988 line accept SUD crisis calls?
Can I try to answer that question, Charlie? Please
do, yes.
The answer, at least in Utah, and I believe in accordance with the federal legislation, would be yes. The overlap of a substance use disorder with a mental health issue is very, very high. And knowing where one ends and the other begins, where maybe somebody's just trying to attempt to self-medicate an untreated mental health issue, is very complex. And so, at least in Utah, the way we're doing it, we really don't distinguish between the two. They often coexist. And so, yes, we are looking at those together.
My suspicion is that it will be determinant on each individual state. In the state of Utah, we deal with behavioral health, which is both mental health issues, diagnosed and undiagnosed, and also substance use disorder.
All right, thank you for that. I'm not seeing any new questions in the audience chat. So again, I just want to thank everyone for logging on today and spending your afternoon with us. We will follow up with you over email if we did not get to your question. But otherwise, enjoy the rest of your day, everyone.
Thank you.